gathered here today, that sounds like a wedding, doesn't it? We're gathered here today to present preliminary one-year results of the PROTECT clinical trial. Dr. Ashley Tung will be doing that for us, and but this is an exciting moment for visioneering. I've been looking at visioneering technologies, VTI, for many years from the perspective of not so much a competitor in my previous job, but looking at what was going on within the space of myopia management, myopia control. And I was always impressed by the feedback that we would hear from within the market here in the US and on a limited basis in parts of Europe. But there was always the need to have some clinical data to substantiate what we were hearing, what the market was hearing. And although there is, 6 years of real live data available that we have analyzed and presented before, what we are presenting today is really, prospective, randomized clinical data. And it's my pleasure then to introduce Dr. Ashley Tung. She will present the data. Ashley is the Chief Medical Officer of VTI. She's been with the company for almost 2 years. She has 20 years of experience within this space, so she knows what she's talking about. She's been involved with large companies, with small companies. She has, I think it's 3 degrees, too, from the Ohio State University, her OD and her master's degree. And she has her PhD from the University of California in Berkeley. So again, someone that has been very much involved in the development of new products. She holds many patents in that area, but also in the clinical evaluation of new products. So I don't think there's many people that are better qualified not only to head the PROTECT study, but also to present the data today. So Ashley, welcome, and thank you very much, all of you, for coming.
Thank you, JC, for the introduction. Are we good? Okay.
Choose one microphone.
I think, how do I turn this one? Thank you. Yeah, so natural view multifocal. The multifocal shape is an extremely aspheric shape. So the extreme asphericity creates an excellent elongated EDOF. And therefore, we are the one and only lens that can do universal ed from emergent presbyope to mature presbyope. But today, we are talking about myopia progression control. Myopia progression control has nothing to do with EDOF because you're not looking at that focal point. We are looking at the myopia defocus. That's what matters for myopia control, and I'm sure everyone sitting here knows about that. There's decades of research using optical defocus to manipulate the eye growth. And the decades of research can be summarized in 3 findings. One is the magnitude that matters. And when we look at the multifocal shape, we need to have the pupil size in mind. There are 2 studies using pupillometers, and then they collected 1,500 data points from kids of different ages. So for the kids that age between 7 to 16-year-old, the average pupil size is between 5.5 to 6 millimeters. Have that in mind, let's look at this optical shape. So as I said, VTI's optical shape, the multifocal shape, is extremely aspheric. And if you look at asphericity, how do you describe aspheric shape? How do you quantify, characterize it? Aspheric shape, another term when you put into describing the shape, is spherical aberrations. Cernicki polynomial, they do the best to describe spherical aberrations. It has different orders. So some, they are larger and flatter. Some are skinnier and taller. They have different orders. So you can use different orders to describe a spheric shape, and you can combine different orders. That's why you have a polynomial. So when a shape is aspheric, the best way to quantify and characterize it is using wavefront Zernike polynomials. And therefore, the best instrument to characterize it is Harman-Shek abrometers. So we went to wavefront dynamics. They have the highest resolution of Harman-Shek abrometers in the market. And they have the latest algorithm to decompose the shape they measured into Zernike polynomial and then convert that into power profile. What you can see here is the lens being measured with the abrometer by the wavefront dynamic. And you can see that the power profile is this lens, is center distant lens. And the transition is really rapid, but it's smooth when it transitions. It progresses into a much higher relative plus. At 6 millimeter diameter of the lens power, you can measure of 8 diopters of relative add. And if you think about children's pupil size, which is between 5.5 to 6 millimeter, you are looking at a relative add of 6 to 8 diopters. This rapid but smooth transition of relative add make the simultaneous optic has minimal visual destruction, so that you can preserve visual quality and preserve stereopsis. Well, there's many optical shapes out there, and some of them have animal data. VTI's catenary curve has animal data that was conducted by the University of Waterloo. They used this shape and then scaled it to the chicken's pupil size. And then they compared to the classic single vision -10 diopter lens. And in the research community, you all know that a single vision -10 diopter lens is going to induce myopia in chicken. So that's one of the control group that is served. And then they evaluate 2 magnitude of the focus from the VTI shape. One I called the full magnitude, which is the commercial product we have today. And one is the half magnitude. Their first study published in 2013, they concluded that with the catenary multifocal design, -10 center, and then with the gradual myopic defocus on the side, the full prescription fully prevented myopia induction in the chicks. And their next study, published in 2017, they look at what happens to the chick that already developed myopia. That means they used the -10 single vision lens to induce myopia in all the chickens in the study. Then they have the control group, which is continuously wearing single vision -10. And then 2 treatment groups. One is the half dosage, and the other is full dosage of the catenary curve. And what they found was the full dosage catenary curve totally, completely, 100% reversed the myopia induced in the first 7 days. And the half dose did some regression, but not as good as the full dosage. So that's our evidence from the animal study that dosage matters, and also this catenary curve successfully manipulated the growth in the chicken eyes. And the next research finding that concluded in the research field is the eccentricity, where the defocus fall matters. Dr. Earl Smith and his team published 2 papers talking about the eccentricity that matters. What they have found was if the myopic defocus is fall on the fovea, it doesn't do much for myopia control. And he said that as the eccentricity increase to the 20, 30 degrees, then the impact is much better. He then compared that with some human studies and pretty supportive. So he recommended that treating large area of the retina will be better for myopia control. Then we have human studies as well. Dr. Jean-Michel and his co-author, this year in BCLA, he shared his finding. What he does is he used multifocal ERG to look at retinal response when you present myopic defocus onto the retina. He has different contact lens designed that will project different sizes of defocus onto the retina, different eccentricity. And what he found was the multifocal ERG response shows the outer retina has nothing to do with anything that's presented, any myopic defocus was presented on the retina. However, if you look at the inner retina, that is the induced component, at the most outer range that multifocal ERG tested, which translates to 15.7 to 24 degrees, that is the sensitive area. You will see the wave change in that area. And therefore, his conclusion implies that this area is likely the most sensitive to myopia defocus. So that means if we deliver a myopia defocus, we want to hit to that near periphery, Dr. Earl Smith called, which is about the 20 degree or so. Our lens definitely covers that region and up to 30 degrees, so you can compensate for different eye shape. And the last point is what we find is wearing time matters, the compliance matters. Study after study, if you look at the compliance, is highly correlated to the treatment effect. And the wearing time also correlates to the visual quality. As I said earlier, any simultaneous multifocal is going to degrade image quality. The question is by how much? That is the holy grail of all the optical scientists out there. How do you design a simultaneous multifocal can least impact the visual quality, but deliver that multifocality that's needed for treatment, whether for presbyopia or for myopia control. So for BTI, we enrolled 20 teenage subjects in a study, and their average refraction is about -3. We compared their best corrected vision with their contact lens wearing vision. And what we have found is if you look at the high contrast visual acuities, distance, intermediate, and near, they are comparable with their spectacle vision. Only when it's low contrast, low illumination situation, there is an average reduction of 2 letters. That's quite minimal for multifocality when you do this kind of test. So therefore, we also find that we were able to preserve the stereopsis. It's comparable with the spectacle stereopsis. And not to mention, the lack of accommodation there is improvement as well. So we are looking at an optical design that has all the right components for a good myopia control contact lens. And then we have animal study evidence to support that. How do we do in human? Natural view multifocal is a marketed product. So therefore, there's a lot of real-world data out there, and they are retrospective. There are 3 recently published studies using the real-world data. One is the 6-year retrospective study published in 2022 that includes 15 clinical sites, 196 kids. And then there's the CAMP study that is published from Treehouse Eye. They put together 2 clinics data. And then there is what we call the Dr. Letterman study. Dr. Letterman is a pediatric ophthalmologist. She presented her own data, so it's 1 clinic, 1 clinician report at the Pediatric Ophthalmologist Conference. So today, Dr. Brett O'Connor, he is going to present, he and his colleague analyzed these 3 studies. They put together a comparison poster, and it will be at 4:30 p.m. His poster number is 138. And he's graciously shared his data with us. Here is a table he put together. He started with the CAMP study. And in CAMP study, there's a subgroup which has monotherapy using natural beam multifocal. So here, look at that natural beam multifocal's response. The age of that subgroup is from 9 to 16-year-old. And he looked at the 6-year data. The 6-year data publication had a subgroup analysis. The subgroup's age was from 8 to 12 years old, or smaller than 13 years old. And then he looked at the Letterman study. Her population is between 9 to 13 years old. These are retrospective studies, so there's no control group. So they used virtual control group by Brennan and Nixon. And he used a virtual control group to calculate the treatment effects in terms of the refractive myopia change, and then also the axial length change. Because the 3 study is quite different, the age is not identical, and then also the sample size is quite different, it's hard to compare apple to apple. But if you look at just the retrospective data, the myopia progressions, you can look at the trend. And the trend says that in these 3 studies, all of them, the average myopia progression was 0.15 diopter or less. And that means majority of these kids, after wearing natural beam multifocal, the progression was a quarter diopter or less. If you look at axial length data, similarly, it mirrors the success of the refractive error control. The progression on average is 0.1 millimeters. He also looked at second year. He only looked up to second year because that's the data available for the camp. So then he looked at the second year performance of the 6-year paper and the Letterman study. And you can see individually the vision change from year to year. I know that some studies shows the first year performance cannot predict the second year's performance. But you look at this individual, they are relatively flat. So some people call this flatlined. And I want to share with you the little known backstory of this 6-year study data. So 8 years ago, at the academy here in New Orleans, doctors were sharing their findings actively, and Dr. Dilley was describing natural beam multifocal's myopia treatment effect to Dr. Dwight Ackerman. And she was describing that how you see the kids' myopia change from year to year, become more and more myopic. And after they started wearing natural beam multifocal, then the myopia stabilized. So Dr. Ron Watanabe walked by, and he said, "You must be talking about natural beam multifocal." She said, "How do you know?" He said, "Well, because I see you were doing that myopia flatline dance." So, 15 doctors get together, they put their data together. That's how we got the 6-year publication. And at the same year, Dr. Dilley was thinking about how do we do a RCT study. But before I go further about the RCT study, I'm going to share one more data point. This is to use the virtual control group to calculate the care value for the 3 studies. 2 of the study, they have axial length measurement, so you only see 2 data points. This is a 2-year care value, which is 0.32 millimeter for both study after 2 years. Now, we know that in real world, that this lens performs pretty good. All right, so the 6-year data, because there's 6 years, we can look at the NNT. So right now, we think about NNT being the criteria is a 3-year performance, and then the success criteria is in 3 years, the progression is no clinical change. So it's quarter diopter or less. So for the 6-year data, then the NNT calculated to be 1. Number needed to treat. So pretty much every kid you treat will have a success. And as I say, the success criteria is 3 years with progression of quarter diopter or less. That's the current real-world study finding. Then it comes to the RCT data. When the RCT protocol was designed, as I mentioned, by Dr. Dilley, she was thinking that, well, what is the best benchmarking study for us to design that study? And she decided that should be the Blink and the MySight study. And then so therefore, when she defined the inclusion-exclusion criteria, she combined the two studies, inclusion and exclusion criteria. For Blink, the age range was 7 to 11 years old. And for MySight was 8 to 12 years old, smaller than 13. And if you look at the baseline inclusion for refraction, Blink is from 0.75 to -5, and MySight is 0.75 to -4. So she decided that it should be -0.75 to -5, all inclusive. And the kids need to be treatment naive. This is a multi-center study. We enrolled 145 kids from 8 clinical sites. They spread between Canada, US, Hong Kong, and Singapore. Naturally, this is the double-masked study. The difference from the 2 benchmark study is the ratio of control and treatment group. This is to adjust the time change that more and more people care about myopia control, and the parents are well educated. If they want their kids to be in a myopia control study, they don't want to end up in the control group because they can lose 3 years of time, valuable 3 years of time for myopia control. So how do we convince the parents to have their kids participate and still feel ethical? All of us feel ethical about it. We do this 2-to-1 ratio. So 1/3 of the chance is in the control group, but 2/3 of chance is in the treatment group. And we also offered, after the kids completed 2 years of study, the control group kid will be crossed over to the treatment group. So for the kids end up in control group, they will get at least 1 year of treatment. We believe that that can encourage the parents to have their kids participate in the study. The outcome measures included the primary outcome measure, which is the change of cycloplegic spherical equivalent refraction, followed by axial length change, and of course, safety measurement. But after this study design, that's quite a few years ago, 8 years ago, time has changed. Everybody focused more on a smaller inclusion-exclusion criteria. So most people talk about 8 to 12 years old. And that's why the treatment, the 6-year data was also analyzed between 8 to 12 years old. And we also wanted to compare to FDA submission, the predicate submission. So we wanted to analyze things as close as possible. So we do have a planned subgroup analysis and modify the population in our SAP. So here is the baseline demographic. The average age of these kids, about 10 years old. And the difference between the treatment and control group are very similar. And the male and female proportion are virtually 1-to-1. We have different races. And because we have sites in Hong Kong and Singapore, we naturally have more Asian eyes. The Asian eyes in this study population is over 60%. And all of these categories are pretty balanced. And if you look at baseline outcome measures, similarly, the 2 groups are very similar. In terms of the average myopia refraction at baseline was -2.4, and the baseline axial length was 24.5. We have planned 1-year interim analysis, which is now. Well, in order to make it to this most important optometry meeting, we have to output our data by September 27. So we have 127 subject data available today out of 136 active subjects. That means 93% of the data is in this cohort I report today. There were 9 subjects exited the study during this 1 year, 6 of them voluntary. So the parents and kids decided that they no longer participate in the study. That's 6 of them, equivalent to 4%. Let's first look at the safety data. We look at vision. If you look at the multifocal vision compared to the single vision, they are statistically the same. 20/20 vision at distance and 20/20 vision at near. Also, the vision is stable from 1 month to 12 months. Let's look at adverse event. There was no device-related serious adverse event. We do have 2 cases, not device-related. One was a broken bone and ended up hospitalized. Another was because of influenza, ended up hospitalized. So we have 2 SAE, but not device-related. When it comes to device-related AEs, we first focus on the ocular AEs. The 2 groups, single vision, multifocal, they have a very similar profile here. And the ocular AEs are very typical contact lens-related AE. There's 1 case reported neovascularization, but it was managed right away from the control group. Both groups reported foreign body sensation, small percentage, 2.4, 2.9%, dryness from both groups, and redness from both groups. They all pretty similar. There is also non-ocular AE, and they judged that it's related to the study and the device, which is headache. 1 subject reported headache from the control group. And after that, rest of the non-related AEs, they are related to COVID or influenza-related symptoms. We also look at, this is preliminary, but we do look at what factors may influence outcomes. We look at lens type. Of course, lens A compares to lens B, there's a difference. Sight influence, age difference, sex influence, baseline axial length and refraction, ethnicity, of course. Everybody immediately, among us in the group, that we jump to, well, what about Asian? We have 66% Asian. Does being Asian make a difference? So what we have found is ethnicity doesn't matter. Being Asian does not change the myopia trimming effect or myopia progression. That's been reported in the study. When you do meta-analysis, that's the conclusion. Ethnicity doesn't matter. Or you can say that the study that we have conducted so far is not designed to find the influence of ethnicity. Or you can say, if ethnicity matters, the influence is probably not as strong as the sex. So that's what we find so far. And now the moment everybody's waiting for. Let's look at the outcome measures of this 96% cohort. The one fact we find interesting is in the control group. There were a lot of non-progressors. That means these kids, myopic kids, enrolled, and then after enrollment, they follow up for a year, there's no change of myopia. That is interesting to us because it's not typical of what we usually see. We have heard from some studies, recent studies, that they have similar experience that the control group has a lot less progression now. So it is what it is for the population during COVID. Our study started at the tail end of COVID, especially in Asia. So the kids' lifestyle changed quite a bit. That's part of it. So having said that, the average progression of the single vision group was minus 0.55. And the average progression of the multifocal group was minus 0.23, making the trimming effect 0.32 diopter. And for axial length, the control group progressed 0.27 millimeters. Treatment group progressed 0.13 millimeters, making the trimming effect 0.15 millimeters. And how about the modified population? The population that we can follow the FDA predicate approval. So we look at the age range at baseline from 8 to less than 13 years old, and then the refractive range from 0.75 to 4 diopter myopia. We look at the difference between the two groups. And then we find there's no baseline differences between the two groups when you look at the age and the cycloplegic spherical equivalent refraction. In this group, the single vision group progressed on average minus 0.59 diopters, and the treatment group minus 0.18 diopters, making the treatment effect 0.41 diopters in 1 year. And the axial length change, the control group 0.29 millimeters compared to 0.12 millimeters, making the treatment effect 0.17 millimeter. So when we look at this data, someone in the group said, this data looks familiar. Where did we see that, right? So this is Brett O'Connor's poster that's presenting today. If you look at the treatment effect, Albion is from virtual control group, but there's quite a bit of similarities. You look at the prospective data, the 1 year change of refraction is between 0.23 to 0.45, and our data showed 0.41. I guess it makes sense because the age range is the same, and then also they have 66 sample size, which is much larger. So our number is much closer to that particular group. And when you look at 1 year of axial length change, the treatment effect of the virtual control group and the retrospective data, both studies reported 0.17 millimeters and same as ours. It could be coincidence, but they are quite close. So we find that we have confidence looking at this data because there's high correlation between the real-world data versus the RCT data. So our conclusion from this preliminary planned 1 year analysis is this product, the safety profile of this study population is similar between groups. And it's similar compared to what is out there as contact lens safety profile. Etafilcon A, one-day disposable alpha-photon. Etafilcon A, this material has 30 years of safety profile. There's a paper called 30 Years of Quiet Eye. So we are not surprised to see the finding. And for per protocol, natural view multifocal reduces myopia progression by an average of 0.32 diopters and axial length elongation of 0.15 millimeters. If we look at the FDA predicate submissions range, then the treatment effect is 0.41 diopters for myopia progression and 0.17 millimeter for axial length reduction. We could conclude from a clinical data's perspective that natural view multifocal may be safe and effective in slowing the progression of myopia. And this RCT data corroborate very well with our real-world data. It should give practitioners confidence when they look at the patient in their chairs that they can predict how the performance for the kids. Thank you.
Want to take any questions from the floor?
Please.
Nice questions, please.
Yes.
So the term care, I don't know if it's a relatively newer term. Could you explain that a little bit and the importance of that in myopia control studies now?
Sure. So Dr. Brennan, he proposed this care value. And the idea is we should look at absolute value when we compare study to study. Percentage is more volatile because it's more relevant into internal study, but compared to others, if the sample size characteristics slightly different, then the percentage doesn't work as well. So that's his idea. And so he said, just look at the absolute value. And we should compare them based on the absolute value and the years that go with it. The care value is designed to compare so that you can compare with ortho K. You look at, let's say, ortho-K, the care value is 0.32 millimeter for 3 years. Then you get a sense of that treatment effect. And then you can look at, okay, so another treatment is 0.45 millimeter for 7 years, something like that. That's the story behind it. Yeah, that's how people look at it if they want to compare different treatment method and focusing on axial length. So for us, right now this data is only 1 year long, so the care value will be 0.17 for 1 year. Any other question? All right. Thank you very
again.
much.
Let me just wrap up here.
Yes,
Thank you,
please.
Dr. Tuan, and again, thank you. So again, 1 year preliminary data, but so far so good. We'll continue with the study, of course. And it's exciting. It's another option, we hope, as we continue to expand the options that ECPs have around the world for the treatment of pediatric myopia. So again, thank you very much for coming this early morning. It was a free breakfast, so I know there's a lot of motivation for that. And we will see you around. And again, thanks for your ongoing support. Have a good day.